right, so tell you what, maybe we'll just get started with intros and we can start getting some questions going. So my name is Sanjay Gupta. I'm an emergency physician and a wilderness educator on Long Island, New York. I'm affiliated with Zucker School of Medicine and Northwell Health. I've had the fortunate benefit of really working with this group of panelists for many years in a lot of different capacities, and we've kind of been very frequent faculty on talking about wilderness medicine topics. But the faculty here is much more than that. I mean, they're a really unique group of individuals who span a lot of different disciplines and touch points, and hence that's why this talk is co-sponsored not only by the Wilderness Interest Group, but also climate change and human health, and also global emergency medicine. So one of the topic areas, I'll introduce everyone and then we'll kind of get to some of the topics. So, the first person to introduce is Dr. Stuart Harris. I'm going to get everyone's titles incorrect. It will correct me for this. But Dr. Harris is affiliated with Harvard University. He's at MGH. He's the chief of the division of wilderness medicine, really the first wilderness medicine fellowship director in the country, starting the program. But much more than that, he has developed a really special career over the years, which bridges the gap with working with NOLS, but also supporting a lot of scientific missions. He's a pretty renowned altitude scientist and has been bridging into climate health recently and climate change. That's just, barely hitting the kind of point of the needle right there with what he's done, and he can elaborate more. And then Dr. Jay Lemery, who is at University of Colorado, formerly of New York Presbyterian, where I actually met him so many moons ago when he used to run a student elective and I would support as faculty, but is a published climate scientist and is a fellowship director in wilderness and climate medicine, but supports scientific missions through the National Science Foundation in Greenland about population, the effects of climate change on human population. So, really interesting and very varied background. And Dr. Henderson McGinnis, who we're still waiting to join, is another really interesting, wilderness physician who is at Wake Forest University, who is a fellowship director in wilderness medicine, head of aeromedical services, former military. He was a river raft guy before he went to medical school, so had a pretty interesting pre-career. Who is a pretty well-established wilderness educator. So that's everyone's background. So the way we kind of conceived this talk was to be a panel, because we thought that would be, the best way to think about the effects that COVID has had on a lot of these programs. So one of the hallmarks of wilderness medicine fellowship training, and even undergraduate training at the med school level, at the residency level, is out of hospital training and kind of out of hospital GME. And, so we had been talking about how COVID has really disrupted so many aspects of our lives, but it's really disrupted our graduate medical education programs, research programs. In all honesty, these, science programs where we've been supporting, NGO work and other things. So just wanted to talk a little bit about that disruption, what that looked like, impact, and also just a creative return, like how we've been agile, how we been able to kind of flex. and kind of what the future looks like with the state of the world and where we are. So that is kind of the framework, and this is why this is great. If you guys have questions, throw them out there, because this is a panel of really diverse experts who can who can really answer these questions in a really great way. Oh, and I saw Dr. McGinnis is in. Welcome, Henderson.
Thanks. They had apparently started it on the app, but not on the web. So.
Okay. All right. So I got your intro in there. I don't know if you heard it.
Man about town.
Yeah, it was all positive. Don't worry. So, so we're about to get into the first kind of set of questions, and so can you tell me a little bit with COVID, as you all have leadership roles in different kind of out of hospital educational programs, that serve a myriad of learners. I know, like, for instance, Dr. McGinnis is involved with, paramedic education, aeromedical education, and I mentioned Knowles with Dr. Harris, and University of Colorado with Dr. Lumry had a really robust CME program, supporting a lot of their work. Can you tell me about, the challenges that COVID-19 actually brought into your educational programs?
Henderson, you want to step up or shall I?
Go ahead, Stuart.
Beautiful. But thank you, Dr. Gupta. It's and Jesse and Robert, if you have any questions at any point, please interject. I think for all of us, it's just been one hell of the last 18 months, and I feel for you as residents that it's in some ways the lack of a frame of reference that this will end is one I hope you're gaining. We will make it through this. But in the early days of the pandemic, when things were first kicking off in China in December, I'm involved with the school Knowles, as Sanjay mentioned, and I'm on the chair of the risk management committee, and we were keeping a pretty close eye on it just because we're a global operation and have things going on all over. And even at that time, and I tend to be, as most emergency physicians are, a professional pessimist, it was like, well, this is bad, could get worse, but it's a regional problem right now. So we had canceled China classes, we had done some other things, but it didn't look too bad. And then on into February, as things were heating up, it was becoming an international problem. It's still, I think the learning point for me has been, it's gone from a go, no go situation that isn't that uncommon in our line of work. So if you're on Denali and it's bad weather, you're not getting out. Similarly, in parts of Alaska and Siberia and other places we work routinely, the Everest area. But so it got down to the point that my fellow Brian Strickland had planned his whole fellowship year around 3 months of research in the Everest area, looking at positive pressure support for HAPE. And we were keeping a very close eye on things and thinking, geez, this is kind of getting a little strange. And it ultimately, he had his tickets all bought long in advance for late February. And by that point, he was flying through Istanbul, and Turkey was having its very first cases. And even then, we were thinking, just don't get screwed, don't get stuck in Turkey. And if you make it to Nepal, things will be good. You're in the Khumbu Valley, you're safe, not to worry. And got him there and was in Kathmandu, got up to the Everest region. And right around then is when the wheels really first started coming off the bus. And it's like, holy cow, this is not, looking so good. Very few country closures at that point, but still was thinking of it, as this is a localized problem. And over the course of about a week, and luckily Brian's extraordinarily resourceful. He was doing this independently with very limited bandwidth. And on our side, we were looking at it. It became apparent to both of us, although not to our friends and colleagues in Nepal, this is going the wrong way and you need to get the hell out of there. You're going to be there for a long time. And started making those efforts. And we're a pretty stable crew. We say we're going to do something, we show up and we do it. But it very just something finally clicked that, this isn't like anything I faced in my prior 20 years of research or experience, and you need to get the hell out of there. And he was already on it, and left everybody in the HRA, his fellow doctors were like, I think you're being a little alarmist. Don't worry about this. And he ended up getting on the very last plane out of Nepal, and they ended up being stuck in Nepal, unable to either practice medicine or to do any research for another 3 months. So if anything I've learned from that is, again, just that uh, the switch from a local situational go, no go to an entire global phenomena was something I'm going to be thinking about for a long time, and hopefully we'll never have to face again in our careers. But it was a useful learning point for me and for Brian.
All right. Thank you, Stuart. Does anyone have a question for Stuart, Dr. Harris?
How did he what did he do when he for the rest? I guess so he had the rest of the spring, right? Assuming he was done July 1.
Yeah, so we typically have
how'd you backfill?
have our fellowship set up for 1 year, and you can do 2 by mutual agreement. So he was planning on 1 year, and just completely, I mean, it wouldn't have happened without the pandemic, but one of the colleagues I have worked with for years on some hypoxia research as a former chair of anesthesia here, and really was the doctor who brought nitric oxide, inhaled nitric oxide for premature births to clinical fruition. And so he was already looking at some of the early data saying that inhaled nitric oxide was virucidal, improved VQ mismatch, was antithrombotic. And so it's like, well, Christ, could this have some good effect for COVID? And so in the course of 10 days, we had gone from this is a keen idea to having an IRB approved study. And I was in charge of the ED version. We had an inpatient spontaneously breathing in a ICU intubated patient population. And so Brian was able to come back while I was getting that up to speed, and he really made that his baby. And so he's coming out of he decided to do a second year, but he came out of that year with emergency department research, which is something I don't typically do. I don't think it's nearly as interesting as things outside the box. But he jumped right into that and was leading this study, and so did beautifully, continued it on throughout the summer, and then ultimately a failure of people who met our demographic. We just closed the study a couple months ago and are getting ready to publish it. But it's, I think it's another example of how expertise outside of the hospital is hugely potentially impactful of what goes on inside the hospital. If we didn't have a deep history of nitric oxide use in the mountains and other places for HAPE, and didn't have the ongoing hypoxia research with Dr. Zapol, it never would have come to pass. So my mom always says you make your own luck. I don't know if that's true, but we got pretty damn lucky on that.
All right, excellent. Thank you very much for the input and your experience. Jay, how about you with your program at Colorado and the support work that you do and the research that you guys do in Greenland? Did you have what sort of experience did you have during that?
It's a tale of three things, really. The first one was we have a pretty robust education program, and we've got we're just doing lots of CMEs and medical education stuff, pre-med courses, and we've got people on payroll. And so that was devastating because as of February, March, we just knew you weren't going to do anything in person, and that had been our model. So that was really rough because that's a conversation with people saying, look, we're not doing this, we can't pay you anymore. So that's layoffs during a pandemic or scale down. And that was really hard because there was just no other recourse at that point. We have since actually, so that was that. Luckily, there was kind of a happy ending where we were kind of able to get people through, they were just hanging on to the point where we ended up being able to bring them back. And part of that was because we were able to pivot a little bit online. So we took some of our courses and put them online, and we were able to get a contract with Coursera to do that. And one of our physicians was like, why don't we do e-shadowing? Because that was a big part of our courses that we did for pre-meds. And we're like, no one's going to shadow for years. And I don't think, students still not going to be back in the hospital. So Elaine Reno put up an e-shadowing course. Very little money, like, $5 a little vignette. And, that was just enough funds to kind of support payroll. So that was the reality of it, which, again, you don't think about the academic mission, but it doesn't mean you don't think about that stuff within the academic mission. But as you build programs, those are the things that we've got to be creative and thoughtful to be able to afford things that just won't otherwise get funded. The dark secret is medical education is there's no big funding for it. So that was kind of our way of funding things that would never get funded. The other thing was we have a climate and health science policy fellowship. And so much of that fellow's opportunity was to be in the room where it happened, and that for the last couple of months, it was having our fellows be in Washington, D.C. Or at national meetings. And that was like all part of the connectivity. So that obviously stopped. And, Hannah Lindstadt, luckily she's just got so much good humor that she's kind of rolled with it. But it's been a disappointing year, I think, because all the wonderful things about being a climate and health fellow, we were able to give her remote access, and she met people. And I think, all things considered, it's been okay for her, but I think that was pretty frustrating. But we've, persevered, and I think she's going to be able to have enough connectivity to have a meaningful career. Interestingly, the third story I want to tell is that Martine Musi, who's actually our wilderness medicine fellowship director, he, as he said in his Argentine accent, he's like, well, we've got a pretty good backyard. It's horrible Argentine, but that was his approach to it, which means we're in Colorado. So luckily COVID was not something that kept us from traveling on airplanes, but not from going out into our wilderness areas. And so we were able to take our fellows and go do a lot of the wilderness stuff that we normally do in the Rockies. So that was actually great. And I think we have a local advantage in that regard, because we've got some pretty spectacular high angle stuff. So Mia Durstein was our fellow, and she was great. She had a lot of great experience. The one thing that was a bit of a bummer was that she was scheduled to deploy to Greenland to support the National Science Foundation's polar research program. That got canceled. And unfortunately, because it's big government, it wasn't just like, hey, it's canceled. It was like, well, we might go. Well, we might not go. Actually, there's another meeting we could go. You know what? We're probably going to go. Actually, no, we're not going. So there's a lot of that as big government forces were all interplay. And so finally it got canceled. But the epilogue of that is that we were able, because the NSF missed last season's research, they pushed it a little bit forward this year, and now she's there now. So she ended up getting to do it before she graduates, June 30. So, a lot of different things there. I think the overall message is that we got through it, and everyone, there was no real, the real tragedy, of course, is just the amount of our patients, right? The amount of people we've seen perish and suffer. But from our programmatic perspective, it was formidable challenges, but I think everyone has sort of reached back to steady state. And so we're just, like everyone else, looking to think about how do we rebuild the future better and, be able to adhere to our missions.
Great. Thank you very much for those insights. So Henderson, and some of the kind of the pre-talk that we had here, you had mentioned in your fellowship how you had some limitations due to COVID, institutionally or locally, but you found some positives that came about from there. So can you discuss a little bit how, despite the limitations and kind of out of hospital GME programs, how you can actually find a silver lining here? So like what kind of innovations did you put in, or what kind
Yeah.
of different?
Thanks, Jay. So I think like Dr. Limmery did as well, we really started to explore our backyard. We don't quite have the Rockies, but we have the Appalachian region. So it's, a little bit different out there. We have flavalanches, not avalanches, but we have a good time out here. Our fellow was scheduled to go and do a lot of international training and some national training like DIM and different things. And so our hospital said no travel, and they were very specific about no professional travel. And if you wanted to do personal travel, there were like tons of hoops to jump through, and basically you couldn't travel. And even I checked in for a flight. I'm flying to Montana tomorrow, and if you read the check-in material for your flight, you can't have had contact with someone who's COVID positive in the last 10 days. So I'm like, well, kind of sure. No, I haven't. It's like I wear a mask. I count that as no contact if I wear a mask, right? But we realized pretty quickly that we weren't going to have national or international opportunities. So we started looking what was available, and one of our faculty members is involved with the state park system, and had really taken a new role as the medical director for the paramedics in the state parks and for all the medical responders. So our fellow really pivoted pretty quickly from saying, hey, I'm going to do a lot of things nationally and internationally, to what can I do locally? And I don't know what you guys saw, but in our region, the participation and user days at our state parks was just off the charts. There were parks that were closing every day at 9 and 10 o'clock because they'd reached capacity. There would be lines out the park for people driving into these places. And even unpopular trailheads were now super popular. So it really presented a new challenge for us, because we hadn't been involved with the state park, medical, structure in the past, and they don't have a formal EMS system. The rangers themselves have different levels of training. Some are paramedics, some are medical responders, and some just have wilderness first aid, but most are just medical responders or wilderness first responders. And so, it was a great opportunity for our fellow to be involved and try to up the educational model and up the sort of content of the folks who are out there providing care to people in our parks. And some of these are really easily accessible, and some are a little more remote. So we really tried to get our fellow to shift into, and we all shifted personally into, how can we get together with people regionally? So we created little pods with a couple other fellowships, and all tested beforehand, and then maintain social distancing and masks when we were inside, and try to do as much outside. But we did on river training with 2 other fellowships. And so we did multiple like overnight trips and on river training trips. And we did some climbing trips and different things like that with the folks in Virginia and Georgia. So we just kind of would meet in West Virginia or meet in different areas. So we found that we were able to reach out to our local neighbors and create sort of a smaller pocket of people. It's a bigger pod than your household pod, but the same sort of principle and concept, and focusing more on the backyard than on the nation. And it really kind of made it a little more palatable than, when you think I can't go to this conference, I can't go to this meeting, I can't get this training, but then you're like, hey, I'm going to meet up with these folks from somewhere else, and we're going to get together. And we did some online things as well to try and connect people together. Just like we had to do the student conference this year completely online, where we normally have a couple hundred people show up in person. And so our fellow got to help out organizing with that and take a role in that, which was a lot more difficult this year, trying to do it online. As you saw, it took me 20 minutes to log on to this stupid meeting. So, and I've been on Zoom all day. And I'm like, why did it decide to kick me off? But so that was really, it was a lot. It was a lot of opportunities that we didn't know were there, that I think we all have in our backyard, and we just don't realize, because particularly from wilderness medicine standpoint, we think about all the stuff that Stuart and Jay do. Let's go to Greenland, let's go to Nepal, let's go to Denali, let's go to the Great Barrier Reef, let's go to this place, let's go to that place, let's go to these awesome places. But we have some really awesome remote backcountry areas here in Appalachia, and I would say almost everywhere you guys are, you can find some remote, really cool areas to do some stuff in. And kind of exploring your own backyard is a nice thing. Just exploring it responsibly, which is kind of the other part that kind of my take on these things. You know, you want to be able to go out. You don't want to send it every time. You want to, I mean, if you can send it, and you can do it, great. If you can pull it off, right? If you can make that move, if you can make that, if you can make that move, then absolutely that's the line you should take. But if not, you know, my walks with boat is commonly referred to me. That's my name. It's just because I'm like, I see the line right over there on the shore. I'm not going to chance that. If I blow it, I'm going to get hurt. And you know, I think one thing we really tried to talk about with our fellow on a real basis and with our residents as well. What is your responsibility in a pandemic? You know, we all got cooped up and we're all super tired of being inside. So everybody goes out to the parks, everybody goes out to do stuff. But should you go out and try new things and, you know, go out and do things that are going to push your limits and be super challenging when the healthcare system's already overburdened? You know, because are you going to put a bigger demand on that, on the rescue personnel, and potentially expose them to risk and expose them to illness and disease by coming to save you? And so as we're, you know, rescuers, some of us work with rescue agencies. And so, you know, how do we prepare our rescuers to go out into the field to pick people up? And how do we encourage people not to go out and do the stupid things that they do that provide our kids to be able to go to school, right? Because that's what emergency medicine is based on, people doing stupid stuff. You know, that's why I advocate. I have a trampoline and a slack line in my backyard for those reasons, right? But you know, so how do we professionally encourage people to be active and go outside, but yet not push the limits?
Yeah, no, I think very good questions and food for thought. I just want to give an opportunity. Does anyone in the audience have any questions just for the panelists, you know, surrounding some of the topics and their experiences that they brought up?
I'm sort of curious how you guys see this all going forwards now that, you know, the CDC is just today changing their guidelines and everything, and what you think next year might look like for medical education and
Yeah, just if everyone, just to reiterate, the question was with changes in the CDC guidelines today and the possibility of things opening up, what does medical education, you know, kind of look like in the next year? And you know, that's a really great question. I think these gentlemen will give you a really wonderful and thorough answer for.
I think it's going to look more Zoomy. I think it's going to be more, you know, online. And I think for a long time, there's still going to be a big lag, maybe not for the matriculated med students, but for like pre-meds getting access to hospitals and shadowing. I think that's not going to be, a viable option. I think for a lot of us, I'm expecting, you know, seeing you guys at SAEM in person, but a lot of the meetings in between will probably be a much fewer. You know, the talks here and there will probably more be going to Zoom, and certainly the meetings are. And I think the home office is going to be a part of our lives, at least the academic part of our lives, for a long time. You know, it's the new reality. So.
So Jay, I think from a climate change perspective, actually, isn't that great that we're going to have a reduced carbon footprint in some respects because we're not traveling as much to some of these meetings?
Totally, yeah, I think so. We've talked about installing metrics here at the med school or Anschutz campus, you know, to track that. And I think the big conversation is, yeah, it's going to be a lot less flights, and therefore having that impact. It's actually really interesting to think about that antagonism between bosses wanting control, and I want all my employees coming in 5 days a week, 40 hours. And then now it's going to be much more palatable for for remote work. What does that mean for traffic? What does that mean for car use? I'm not going to get futuristic here, but we know that the ride sharing is going to become a bigger and bigger part of our culture. And so at some point, is the American family going to spend $20,000-$30,000 on buying a car when they can, some people are saying 10 cents a mile for ride sharing? So it's exciting. Yeah. I mean, those are that's what makes me optimistic.
I think
I'll be the professional pessimist. But I think in that regard, I think the likelihood that human nature is a pretty durable phenomena, and I think we're going to probably fall back into old habits more readily than we would like. We're recovering carbon users, not recovered carbon users. I think the hard part for me is that I've always had an open door policy. If anybody emails me and says, I'm interested in wilderness medicine, I'm interested in EM, it's like, sure, come on in any shift I'm working, you're welcome. And that, I think, is probably, at least for the foreseeable future, not going to be the case. I think domestically, with increasing rates of vaccination, we're going to be able to do a lot of the things. I think ASAP will probably come off in person. I think SAM will come off in person. Board meetings that we're planning for after midsummer, I think will come to pass. And I think we're all feeling it. The loneliness and the lack of direct contact, it's wearing, and it impacts our ability to do our jobs. And so in some ways, we want to do everything we can to minimize needless travel, but some awareness that, the chance to chat in meetings is, or in between meetings, is sometimes when the best, most interesting work gets done, isn't something I hope we'll give up easily. So I think it's finding that balance, and hopefully we can, I don't know, I'd structured my life professionally that if I didn't have to be on the hospital campus, I was working from my home office, and my boss was well aware of that for the last 10 years. So my life hadn't really changed a whole lot in that regard. And it's something that if I had a choice between, driving 30 to 40 minutes each way or going on a good bike ride every day, it's like, why in the hell would I get in a car? So in that regard, I think hopefully, and just, in my world of mountain biking, I'm seeing a hell of a lot more people out than I did 18 months ago, and pretty durably. And I think that's a good thing. It always struck me as amazing that I could go on a 10-mile ride this close to Boston and see nobody on a beautiful sunny day. And so in some ways, that's a good thing.
Well, and I think you really hit on a really important part there, Stuart. The personal connection that we've made. So the four of us on this panel all met through SAM, and through you starting the Wilderness Medicine Interest Group. And so this career of ours really has sort of sprouted from that seed you planted, and from getting together and meeting there. It's a little bit more difficult virtually to make those connections, because we sat at that table for hours, it seemed like, till we got kicked out by the next group that came in. And and so it's, you don't have that with the Hollywood Squares Brady Bunch that we've got going on right now. You can still do it. It's harder to make those introductions and those connections. But to those of you that are on the call, all of us on here are super willing to help anybody. The other three folks on here with me have consistently been people I've turned to for advice and for help and for counsel and things. And so they would reach out to any of us anytime with any questions you have. And we're here to be resources for you, because that's why we do this.
Excellent. I think this is a great conversation that might actually lead into this next question. So I had the opportunity to speak to someone that we all know, who is a pretty well-renowned public health physician and global health physician, who is on the board of MSF for North America. So just about his experience when the pandemic started with MSF and supporting programs. So MSF is Doctors Without Borders, in supporting programs. So, you know, their experience with MSF was early on, it was very much just like the stories that are told here. You know, luckily for a lot of the programs that are supported by MSF, they have a lot of local talent and local workers. So it was really the expats that had to leave. And there were, you know, several countries that did not then allow workers in, even with taking precautions about, you know, PCR testing and even quarantining and coming into the country. And some examples are like Burundi and South Sudan. The idea is resources that, you know, they had cases in the beginning where foreign travelers were bringing cases of COVID in. You know, the country of Burundi has 10 ventilators for the whole country. And so even, you know, despite that, even with kind of MSF coming and trying to create some dialogue and even coming up with pathways for kind of safe travel and safe quarantine, the access is kind of variable. So I guess as, you know, wilderness physicians and as climate scientists and as global health physicians, so where do we fit into kind of the global reopening for out of hospital GME programs, for scientific support programs, for work with NGOs in countries that need support? So, you know, where is our you know, kind of value, and what can we bring to this conversation?
It's a big question. It's a big question. I think I'm just going to revert back to something we talk about a lot in the climate world. We're science communicators. We're people centric. We're adventurers, and we can probably craft all those complex narratives, as our colleagues have done on big media and as we have done in small media. You know, and explain why we're going back out there, why it's safe, why it's important, and perhaps most importantly, contextualize it in the framework of just what has just happened. If we don't pause and acknowledge a global trauma, I think we're missing the point. And I think that to me is something that we can play a large role in crafting that narrative of processing what that beep just happened.
Yeah, I think Dr. Limrey's spot on. And just medicine is the most human of the sciences, and we every day put complex situations and complex data into an actionable narrative. We tell a story, and that's how we talk to our patients, and we don't even think about it. And it's a screaming need right now. As far as going forward, I continue to be very aware of just the differences between countries. I was supposed to be at a meeting in Switzerland like in 3 weeks, and that was canceled. And we're supposed to be back in Nepal in early 2022. And as things are playing out in India and to a lesser degree in Nepal, you know, that's very much up in the air. So I think things will evolve in a pleasant fashion in the United States. But if you're looking internationally, I think it's going to have to be a bespoke, you know, looking at where you're going. I didn't really mention at all the other fellow, Ashley Kuchanik-Wiseman, who for her year was planning on being up in far northwestern Alaska, working with some of the Native Alaskan corporations there, Manilik. And she ultimately, because of a robust telemedicine presence there, was able to get there on the ground before things got bad. And then even when things were ramping up, was able to institute ventilator management and supply chain management, other ways of helping a remote resource limited institution come to terms with what was anticipated to be a devastating pandemic. Just if you look at the death rates in the Native Alaskan populations from 1918. I mean, they had whole villages disappear, and we had no reason to expect other than that this time. So even when she wasn't able to physically be there in the early days, it was a huge value add. So I think that's something that we as a community will continue to offer to people who are, especially in underserved areas, just with the expansion of telemedicine and just communications. There's nowhere on the planet you can't be and not have expert physician coverage at some level. And I think that's just become more and more clear.
You know, that's excellent. I think that's a great parlay into like how you're ending on the positive, is that, are there aspects of this, pandemic and the way it has disrupted our graduate medical programs and kind of remote medical services that, that actually are positive? Did we pivot in a way that are, you guys have mentioned durability of, kind of human nature and activities, but, is there a silver lining in this? If you guys could think about, all the actions that you had to take this year, and look at a positive. And I'll give one example. Henderson mentioned his student conference, and even with our pre-conference that we had earlier in, workshop, not pre-conference anymore, workshop that we had earlier this week, we pivoted to kind of figuring out a way to do improvised medical medical education on improvisation via Zoom. And, we devised a method to create a kind of low cost way to do a remote, telehealth simulated, education kind of focused on improvisation. So I look at those two things as a positive, that, we were able to kind of push the boundaries of what we, generally have relied upon as kind of durable and expected, kind of stalwart, curricular tactics or, teaching tactics in wilderness medicine. We were able to flex this, and it's something that might actually might be something that we continue even when we don't have to. So that's you guys have known me for a long time. Brevity of words is not my forte. So if you could think about like a positive that comes out of this, that you think that we might continue, I mean, I think that'd be great to share as we think about the wilderness medicine community, the climate community, or even the global health community.
I think of two things. Oh, sorry, go ahead, Stu.
Well, no, the thing that I think has been most useful for me and gives me real reason to hope is just we saw in the course of about a month how forces that we think of as being obdurate and durable and unable to change in a nasty way. So our energy policy, some of our foreign policy, and other ways that healthcare policy is kind of lost and separated from bigger societal concerns. With the fulcrum of a little virus, it became very clear that human health is part of a gigantic system, that we are an ecological phenomena. And it's been true since we started. But I think a lot more people are aware of it, and federal government, state government, individuals, just the ability to see that we can ride a very thin knife's edge between being quite happy and seemingly stable in the wheels falling off the bus. And this was one little virus, and we're talking about mass changes to the environment, to the climate, loss of biomes. So I think it's a good preview of coming attractions that if we don't take thoughtful steps now, we're going to inherit badness. And I think just as a population of 7+ billion, we have new familiarity with, wow, this can get bad. And I think this was, again, this wasn't an influenza pandemic. We've got another pandemic coming our way. It's going to be a lot worse. We got off pretty easy this time, but I think that sense of, we need to be thinking and and just mindful of, how damn good we've got it across the world, and how things could be a lot worse, if we don't kind of be thoughtful. I take that as a great win. I think our species unfortunately needed it.
I think you really nailed it, Stuart. I think the other part is just the ability for folks to just be a little flexible and adaptable. You know, it's like, this is the way we've always done it. This is the way we have to do it. And the fact that we were able to really shake things up and look at things again and say, we don't have to do this way. Maybe we could do it a different way. Maybe there's another way that's a little more efficient. And so I think having, just having us apply that to a lot of things in our daily lives, like, do we really need to do this? No. Do we really need to go to this place? Do we really, like all these stupid meetings that people would have to go to, drive to campus and go to a stupid meeting. You're like, just making an email that I can ignore, right? Instead of a meeting that I don't want to go to. But, and I think that, we've changed a culture in a way. And my wife and I, we really, our hope going through this process was that the world would come out with people being in a better place and more respectful of each other and more respectful of the earth itself, and hoping that people would just, be nicer to people. And I don't think we're quite there yet, but I'm hoping that we're moving in that direction. I'm hopeful for that.
All right, Jay, what do you think?
No, I'm just going to echo. I know we're out of time, but the two things I thought of is, one, the very practical, innovation, which Henderson seemed to, and you talked about, Jay, is ours was kind of stumbling upon some online learning that seems to have value. So that was kind of very practical. The other is just the palpable inequity that's so close to home that maybe felt a beat further away in years past. And I don't mean EM, I mean our society. And so I think me and our group have talked a lot about repurposing what it is and why we're doing what we're doing, and how do we make that much more focal to our mission. And it's a very robust conversation. I don't know that I have any great answers, but I think we're deeply affected, as I'm sure you all were, about just what Stu said, the last 4 years, and then the last year, we're really hammering that point home.
All right, yeah, and just thank you all for the comments. I just want to give anybody from the audience another opportunity to ask maybe a parting question, and then I think we will be out of time after that. And if there's no one, don't feel inclined. Don't feel pressured. So.
Yeah, Dr. Shriek has already won the game, so.
Yeah.
Give it up for Shriek.
Congratulations.
Yeah. You have three different fellowships now that you.
That's right. You get an automatic fellowship bid. Well done,
Yeah,
sir.
absolutely. Come on down.
Thanks to everyone at SAM too.
All right. Well, excellent. Thank you. Thank you guys for this conversation. I think it's valuable just understanding that, we had a shared experience, but also, shared a lot of different pathways and perspectives on, how to navigate and how to come out of this positively. And, hopefully, we'll be able to do this again in person next year.